and good evening, Dr. Natan Bornstien. It's my pleasure to introduce Professor Natan Bornstien. He's an internationally renowned stroke neurologist. For most of his career, Professor Natan Bornstien has been chairman and head of the stroke unit at Tel Aviv University. In fact, I have visited his stroke unit and I have taken a lot of inputs from his stroke unit, which we implemented here in India. And I can say that Natan, as he likes to call himself Natan, is father of modern stroke care in Israel. In 2016, Natan gave up his administrative responsibilities and devoted himself completely 24/7 into the leadership role of stroke care, not only in Israel, but in the whole world. Since then, he has been the director of the brain division of the Share Zadok Medical Center in Israel, and also chairman of the Israeli Stroke Society. Natan has been for many years chairman of Israel Neurological Association also, and he has also been for many years vice president of the World Stroke Organization, where he still continues to play important role. He's the consulting editor of the Stroke Journal. Natan's involvement with India began almost a decade ago, which he may be remembering, when he was the principal investigator of the clinical trial of sphenopalatine ganglion stimulation in acute ischemic stroke. In fact, the first case of that trial was done in Nizam's Institute of Medical Sciences by us, and Dr. Manas, if he's here, was the one who operated, and soon it was taken over by many other centers, most notably Dheeraj in PGI Chandigarh and many others. Natan has been regularly visiting India, and he has addressed several times in the meeting of Indian Stroke Association. He has also been a fine speaker and has given lectures in the fine meetings on several topics. Presently, Natan visits India at least once to have a debate with me in Goa, and we have a stiff debate on the stage, but at the end of the debate, we share our glass of wine. Natan is a great lover of wines, and in fact, with each year, like old wine, the friendship is only deepening and deepening. Natan is a true friend. I can tell you that he is a friend of India. He's a friend of Indian neurologists. The moment I requested him to give this webinar, he readily agreed and said that anytime we can call him for, in future also, for any webinars. So Natan, I welcome you to this very important topic of secondary stroke prevention with particular emphasis on the antiplatelet drugs. Over to Natan Bornstien.
Thank you very much, Kaul, Subhash, my dear friend, and all my dear colleagues and friends in India. I hope that you are all well in spite of these difficult times. And it's really a pleasure and honor to share with you this knowledge about the secondary stroke prevention updated with the stress and emphasis on antiplatelet. So thank you again for joining, and thank you again for inviting me. I always feel amongst friends in India and really very fond of India, Indian people, and of course the Indian neurologist. What you forgot to say that I'm also an honorable member of the Indian Stroke Society. So let's start. We all know that we don't have to tell you guys that the burden of stroke is enormous. Stroke is now the second leading cause of death and disability. Surprisingly, lifetime risk of stroke increased by about 50% from 1 in 6 in 2000 to 1 in 4 in 2016. And also, there is a global known that the percent of increase in mortality in the middle-aged people in the US. But stroke is a preventable disease. And now we're talking about secondary stroke prevention, not the primary one. So this is just remind us that stroke is not one disease. It's not like myocardial infarction, that you have a rupture of plaque, clot, blocking the coronary artery, boom, myocardial infarction. Stroke is divided into major main categories. The intracerebral hemorrhage, which is not the topic of our scope of the topic of this afternoon, but the ischemic stroke, which is of different type of etiology, and the TOS classification of acute ischemic stroke subtypes is well known to all of us. And about 1/4 is large artery atherosclerosis, mainly carotid artery, but also aortic arch. Cardioembolic stroke, which is probably more than 25%, mainly due to AF, lacunar infarcts, small vessel disease, and other, which I call the exotic stroke. But we have to emphasize that about 1/4 of all ischemic stroke is an unknown etiology, which is cryptogenic stroke. And by the name cryptogenic, we actually mean many things. Non-investigated enough, multiple causes, and really cryptogenic. I'm not going to dwell on it, and specifically not on the ESUS part of it. This is the ESUS, is the subtype of cryptogenic stroke, because I'm voluntarily willing to talk about it next week on whether ESUS is a valid concept or whether the ESUS is a hidden AF. But I'll talk about altogether is just to show that reducing the burden of stroke in the population requires identification of modifiable risk factors, of course, and tailor the right treatment to the right patient. It's not the same if the etiology is due to symptomatic severe carotid stenosis, where intervention should be performed, or atrial fibrillation, when anticoagulants are being the first choice for treatment. So what I'm saying, we have to tailor our treatment to the subtype of etiological aspect of stroke. However, having said all that, we know as a strokeologist that antiplatelet for secondary stroke prevention is the bread and butter for a strokeologist. And today I'll try to show you what are the evidence-based medicine for antiplatelet in secondary stroke prevention. So antiplatelet, there are various types of antiplatelets. You all know about it. We are familiar with the aspirin, the COX-1 inhibitor on one hand, and we have this Clopidogrel, diclopidine, and prasugrel, which are the P2Y12 antagonists. This is from the family of the TNO-pyridine. These are the irreversible one, where the active metabolite is the one that does the job. And we have also the other group, which are the reversible P2Y12 antagonists. And mainly for us is ticagrelor. I'll talk about it later. And also we have the dipyridamole, which is the cholesterol inhibitor. I'm not sure whether it's available in India. And this is the Agrenox. That is a combination of ticagrelor, phosphodiesterase inhibitor, dipyridamole plus aspirin. And of course, the final common pathway, which is the GP2B3A blockers, but we don't have anyone available orally. So these are the four main players, where in a simplified way is just to emphasize that each one of them do suppress platelets aggregation, but in a different mode of action. And I'll come to it later. The aspirin, clopidogrel, and dipyridamole are acting in a different mode to suppress and inhibit platelet aggregation. So these are the players that you can see here on the picture. The good old aspirin, Plavix, Agrenox, Purilinta, which is ticagrelor, and also cilostazol. I don't have enough experienced it is the Japanese antiplatelet, which is similar to the dipyridamole phosphodiesterase inhibitor. So let's start with the aspirin, the good old aspirin. This is in Leverkusen, where Bayer celebrated 100 years of aspirin. And if taking all together, the many studies that were done since the late 1970s to the 80s, last century. And if you take all of them together, this is the meta-analysis done in 2006 by Alvira, Van Geen, and Johnson, Clay Johnson. And it doesn't matter if you look at the low dose, medium dose, and high dose, all together, the aspirin, the relative risk reduction of stroke by using aspirin is around 15 to 20% max. And with, as you can see here, this is a very kind of modest effect on secondary stroke prevention. We all send our patients back home on aspirin, and they think that they are all protected, but the reduction of recurrent stroke is only by about 15 to 20%. So therefore, for many years, we've tried to find a better, more potent antiplatelet in order to prevent stroke. This is just a slide to remind me that for the question and answer period, we can talk about the aspirin resistance, or what we call pseudo-resistance, which I think that we should discuss, but for sake of time, I don't have time to dwell on it now. So the next antiplatelet, Clopidogrel, which was replaced by a better cousin, which is the Clopidogrel, and we're all familiar with the Capri study. Capri is a very nice island for those who are looking for honeymoon. It's a very nice place where they compare Clopidogrel 75 milligrams to aspirin, at that time 325 milligrams. 19,000 patients were involved with different type of atherosclerosis, from recent myocardial infarction, recent ischemic stroke, and peripheral arterial disease, established peripheral arterial disease. Then overall, after about more than 2 years follow-up, the Clopidogrel was found to be slightly, but significantly more effective than medium dose of aspirin. As you can see, the relative risk reduction of 8.7% on top of aspirin. However, look carefully, only 0.5% absolute relative risk reduction, which comes to number needed to treat 200. As a clinician, we may ask whether NNT of 200 is clinically relevant. And if you look at the subgroup analysis within, this was published in The Lancet, I was a reviewer of that, and the Lancet editor asked to do this subgroup analysis. You can see of the 600 plus patients that were involved after ischemic stroke, there was no significant difference between aspirin and Clopidogrel, which means again, that maybe the Clopidogrel has a very slight, a more effect on reduction of stroke risk after the first one, not very much so. Therefore, there was an idea, if the Clopidogrel and aspirin are both antiplatelet, but acting in a different way, in a different mode of action, maybe combining both will have maybe synergetic or additive effect. And there were 3 trials trying to look at long-term, I emphasize long-term secondary stroke prevention with dual antiplatelet, Clopidogrel plus aspirin. The most known one to us, psychologists, is the match study. 7,600 patients were enrolled to get either clopidogrel plus aspirin against clopidogrel. And without going into details, you can see here that there was no significant difference between the monotherapy on clopidogrel and on clopidogrel plus aspirin. Relative risk reduction 6.4, not significant. However, if you look at the benefit, net benefit effect, which means taking in consideration the side effect, the adverse event, you can see there was a slight decrease. However, there was an increase in bleeding, double the bleeding, major bleeding and life-threatening bleeding, which means that the net effect was at 5 additional events. Another study was the Charisma, 50,600 patients. Again, look at this, 7.1 relative risk reduction with aspirin in this case, plus clopidogrel against aspirin, not against clopidogrel, but against aspirin. Again, not significant. And finally, if you look at the SPS3 study done by Oscar Benevente from the United States, sponsored by the NIH, you can see that dual antiplatelet in lacunar infarct, it was specifically done in small vessel disease. Clopidogrel plus aspirin after lacunar stroke, no significant whatsoever. Look at the Kaplan-Meier curve. However, if you look at the hemorrhages, again, almost double with the antiplatelet. Therefore, the guideline that was established in 2014 said no dual antiplatelet, no DAPT is recommended to prevent long-term stroke, recurring stroke after the first ischemic stroke, because there is no significant efficacy, but definitely there is increased risk of major and fatal hemorrhages. But when the analysis was performed, it was found that the bleeding occurs 3 to 6 months down the road, not immediately. So people were thinking, maybe if we give this dual antiplatelet for a short period of time, maybe which is the most vulnerable time, the first 3 months, for recurrent stroke, maybe you will have the benefit of the dual antiplatelet without the adverse effect of hemorrhages. So for that, there was the first study done in China, more than 5,000 patients included in a small village of China, and they gave this aspirin plus clopidogrel with loading dose of 300 milligrams plus 75 milligrams daily for 90 days, but the combination, the DAPT, was given only for 21 days. And they found the hazard ratio 0.68, which is 32% relative risk reduction, significant. This was the first evidence that short-time treatment with DAPT may have benefit with no additional hemorrhagic adverse event. In parallel, there was also a NIH-sponsored study, and they decided to continue with this study in spite of the very significant results of the Chinese study, because they said, okay, in China, maybe it's right that we have to repeat it in another population, Caucasian population, and they've established the point study, and the point study was included TIA or minor stroke patients, and the TIA was people with ABCD2 above 4 to enrich the population at risk, and minor stroke with NIHSS less than 3. This time the loading dose was 600 milligrams, not like 300 milligrams of the Chinese, and they given the DAPT for full 90 days. This is important. The Chinese have given it to only 21 days. And the results, this was published in the New England Journal of Medicine, as you can see. And if you look at the results without, you see there was a significant benefit, reduction. This is aspirin, this is clopidogrel plus aspirin, and there was 25% relative risk reduction or hazard ratio of 0.75 in the combined endpoints of stroke, MI, and vascular death, with one caveat. Look what happened to the hemorrhages. The hemorrhages start dripping like here and increase, and there was significant major risk of major bleeding. So now we have two studies. One is a chance and the other one is the point. And the question is, and with a slightly different design, and this was published in Stroke in 2019, a meta-analysis of all the trials that try short-term DAPT in acute ischemic stroke for secondary stroke prevention. And they found that aspirin plus clopidogrel is more effective than equally safe in comparison to aspirin alone in patients with ischemic stroke or transient ischemic attack in the short time. In the short time means less than 1 month. They have short time, medium time, and long time, and they found that the short time is the best one. And although it's not written yet in an official guideline, it seems that with the time-sensitive analysis, the 21 days is the way to go with DAPT after TIA or minor stroke to reduce secondary stroke, recurrent stroke, and without the hazard of hemorrhage. So these are the evidence for DAPT for short time after ischemic stroke. Again, this is a slide to remind me for the discussion regarding the issue of Plavix resistance. And not just resistance, because there's kind of mutation in the chip cytochrome that may affect the transformation of the clopidogrel into the metabolite, the active metabolite. We can discuss it later in the question and answer. This is another DAPT, dipyridamole 200 milligram plus 25 milligram of aspirin, giving twice daily, called the Agrenox. And the Agrenox was tested in many studies, but finally the last one, which I was on the steering committee on it, it's called the PROFESS study, published in 2008. All these studies are quite old, more than 15 years or 12 years or 10 years. And it was shown again, Agrenox, which is again dipyridamole plus aspirin against Plavix. Look at this, no difference whatsoever. And there was a slight increase bleeding in the Agrenox. So again, I think that so far we can see that long-term DAPT is not effective. There are more hazards in the DAPT, and within these three antiplatelet, aspirin, Clopidogrel, and dipridamole, there's no really major differences in the effectiveness and the efficacy of reduction of stroke. Just to show you a new approach which was shown in cardiology in patients with stable coronary artery disease. It's called the COMPASS study, where they tested rivaroxaban, low dose, 2.5 milligrams twice daily, with aspirin in this particular cohort of coronary artery disease. This was a multifactorial design, double-blind, randomized study. 27,000 patients were included with established atherosclerosis, either peripheral arterial disease or a stable coronary artery disease. They were randomized into this rivaroxaban, low dose, twice daily, 2.5 milligrams, plus aspirin, rivaroxaban alone, 5 milligrams, and aspirin alone, and the endpoints were the composite endpoints, stroke, MI, and vascular death. Look at the results. This study was stopped because of superior efficacy of small dose rivaroxaban plus aspirin. Within this particular cohort, there were patients with asymptomatic carotid artery disease. And in this patient also, it was shown the low dose rivaroxaban plus aspirin was superior of rivaroxaban alone and aspirin. So this was a small group of patients. And if you look at the overall, surprisingly, they found the stroke was mostly significant subgroup of patients. The stroke reduction was very significant, and that was surprising because it was a cardiology study. So rivaroxaban plus aspirin more effective compared to rivaroxaban or aspirin in reducing stroke in this particular cohort of atherosclerotic coronary and peripheral arterial disease. So, however, it's not the cost of major bleeding. The rivaroxaban plus aspirin causes major bleeding. So the question is whether in the future we maybe will have a study in particular stroke patients, ischemic stroke patients, to see whether this combination might be effective in reducing stroke, recurrent stroke in this particular patient with stroke due to atherosclerosis. We'll see. There is a study that are planning currently. So, having said all that, the question is whether we have reached the ceiling. Means that whether we actually cannot add any more of any antiplatelet that will do better than these three musketeers, aspirin, Plavix, and dipridamole. However, in cardiology, ticagrelor is the drug of choice, and it's better than Plavix and the others. So the question is whether we can try this, ticagrelor, Brilinta, in stroke. And there was a study, probably all familiar with, Socrates, in patient acute stroke, and ischemic and TIAs randomized into aspirin alone, antiplatelet loading 180 milligrams versus and then ticagrelor 90 milligrams BID for 90 days. The results, this is published in 2016. Clay Johnson was the principal investigator together with Pierre Amarenko and others. And you can see here, 13,000 patients were, more than 13,000 patients were randomized. The primary endpoint was in 6.7 versus 7.5 in patients treated with aspirin alone, and it was not significant. Fortunately, you can see here, and there was aspirin and ticagrelor, hazard ratio of 0.89, not significant. And if you look at ischemic stroke alone, not just the composite endpoint, again, hazard ratio 0.87, not significant. However, Pierre Amarenko was championing the idea that these 13,000 patients that were recruited were not the appropriate ones. He looked at the subgroup within the Socrates cohort with known atherosclerosis, actually investigated by Doppler ultrasound. And without further ado, it was published in the Lancet Neurology in 2017, February. And it was found that in this particular subgroup of patients, there was a hazard ratio of 0.68, and which was definitely significant in favor of ticagrelor against aspirin. So it could well be that had this study was performed in those with atherosclerosis, because antiplatelets are supposed to prevent atherosclerotic stroke, maybe that was the next study, which the results will be presented virtually in the ISO-WSO meeting in Vienna. Was supposed to be in Vienna, but we decided that probably the randomized control study with the results will be presented virtually. The HALET results will be presented, and we all hope to see whether ticagrelor versus aspirin in atherosclerotic stroke is beneficial more than aspirin alone. Another piece of information to support this idea is this study, ECLUDE, and this was done in PAD patient, established PAD patient, and then without going into detail, the use of ticagrelor compared with this time Plavix was associated with lower adjusted rate of ischemic stroke, all cause of stroke, and ischemic stroke. And these are the results. As you can see here, the all over strokes, and this was significant. And if you look at the ischemic stroke alone, also significant. So another piece of information. And although the American guidelines based on the Socrates do not recommend ticagrelor, but probably we'll hear more about it in the near future. Just another practical point before I finish. The practical point is coming from the Oxford population-based study with Peter Rothwell as the leader of this group. And it was shown that aspirin, patients receiving aspirin with not coated aspirin, this is in England, if you don't add PPIs in the elderly group, they might have major bleeding and fatal bleeding. And this is the data. If you look at non-major bleeding, there's no difference in the age group. This is the age group here. And this is no different between any bleeding while still receiving antiplatelet and bleeding while receiving antiplatelet excluding aspirin. However, look what happened here. Above the age of 75, these people, these cohorts, suffer significant more life-threatening fatal bleeding, life-threatening and fatal bleeding when it reaches 75. And if you look at major bleeding alone, again, the same effect. They recommend to give PPIs to patients on aspirin above the age of 70, 75. So I should recommend to you to do the same in your patient. Another question that we still don't know the answer, and this is the RESTART study, very recent one, in June 2019. This group looked at patients that had intracerebral hemorrhage while on aspirin. And they divided this group randomly into avoid antiplatelet, in this mainly aspirin, or continue antiplatelet, and the median time from restart this group that were randomized to restart was 76 days. And they found, basically, this was 537 participants were recruited, median age 76 days after the hemorrhage, and patients were followed for 2 years. They found that the results exclude but a very modest increased risk of recurrent intracerebral hemorrhage, and the risk of recurrent intracerebral hemorrhage is probably too small to exceed the established benefit of antiplatelet therapy for secondary stroke prevention, which means that if you have a patient who had a stroke, who had a hemorrhage on aspirin, to restart aspirin is of benefit without major or very small risk of recurrent hemorrhage. And this is the graph that shows it. This is the red is to avoid, and this is to start, and you can see there's not much a hazard of bleeding, or recurrent bleeding in this particular group. Finally, having said all that, we should not forget that antiplatelet is not the only secondary stroke prevention approach. We need to treat all the modifiable risk factors in order to prevent stroke, and the interstroke study, which included 32 countries and with 13,000 cases, it's shown that if you actually control all these modifiable risk factors, you reduce the risk of ischemic stroke by 91%. 90% of all this, and this is population attributable risk, the power, 90% you can reduce the risk of stroke. And this is just the measure, this was the measure of the studies. You can see the metabolic risk, high blood pressure, high body mass index, and all this, you reduce it by 72, 62, and all risk factors together, you reduce the risk of stroke by 88.8%, almost 90%. We should not forget that the major component in secondary and also in primary stroke prevention is to reduce the modifiable risk factors. So in summary, stroke is largely preventable disease. Aggressive risk factor management is important. Antiplatelet have almost similar efficacy with marginal benefit of clopidogrel or aspirin plus dipyridamole over aspirin. There is a whole story of polypill concept that is currently under investigation with the WSO, the World Stroke Organization, have a project of cutting stroke by half with this polypill. So we all know there is no health without brain health. So keep your patient's brain healthy. Thank you very much for your attention. It was a pleasure to be with you this afternoon, this evening. Thank you.
Thank you, Natan, very much for this very comprehensive talk which you gave within the time frame. Now, I got a lot of questions, and I'm going to read the questions one by one, and we can do a rapid fire. Let me tell you one more thing, that this talk was mainly with the emphasis on antiplatelet agents, because I see there are a lot of questions on cardioembolic strokes and embolic stroke of uncertain etiology. We are going to have it next week. Today we'll mainly discuss about antiplatelet agents. So the first question is that when we give a dual antiplatelet, which seems to be the practice now in the minor or strokes or TIAs, when we give dual antiplatelet, should we give them in a fixed dose combination, which means the same tablet containing both, or should we give them separately at different times? Is there any data on this?
The practice that was performed, this question was asked to the PI of the two studies, and the practice was that actually was not homogeneous, so we cannot tell anything regarding what I do. I give them both at the same time.
You give them at the same time, and do you give them in the same tablet? Because we have got here many combination tablets.
No. We don't have it in the same tablet. So I give aspirin and Plavix alone, but give them at the same time.
Okay. Now the other question is that since we know that the CHANCE trial showed that you can give the dual antiplatelets up to 3 weeks, but the POINT trial showed that you can give it up to 3 months. So what should we do in the real practice? Should we give dual antiplatelets up to 3 weeks or 3 months?
The fact that, as I've shown you, the bleeding in the POINT study started to creep up after 21 days. And therefore, and in that time, as it showed, there was a significant more hemorrhages in the dual antiplatelet given for 90 days, but the bleeding started after 21 days. Therefore, combining the two studies together, Clay Johnson was the PI of the POINT, but also was observer of the CHANCE study. The time-sensitive analysis showed that 21 days is the right time to get the most benefit without the hazard of hemorrhages.
So 3 weeks may be a better choice than 3 months.
Yes.
Now there is a related question. That Socrates trial showed that if you have got a very significant intracranial artery stenosis like ICAD, they have given the double antiplatelets for 3 months. So if you have got a patient who have got a tight MCA stenosis, would you give them dual antiplatelets for 3 months going by the data of Socrates trial?
I'll go by the data that we have. I'm not sure that there is difference between major artery like the M1 stenosis and maybe small vessel. You know, all these studies that were done, POINT and CHANCE, were done on TIAs or minor strokes. The others, the Socrates was done on major artery. So, and they found that 3 months dual antiplatelet plus aggressive treatment of risk factors is beneficial. So I'll go for the M1 stenosis, major intracranial stenosis, for 3 months.
You'll go for 3 months.
Yeah.
So if
Dual
there's a major,
antiplatelet for 3 months.
yeah, so if there's a major arterial stenosis, you will go for 3 months.
Intracranial.
Intracranial. If there's the intracranial stenosis, you will go for 3 months. But if it is a lacunar stroke or there is no major obstruction, then you will keep it only 3 weeks. That point is well taken. Now, the next question is, what if a patient gets a recurrent stroke in spite of dual antiplatelets? What do you do? That in spite of dual antiplatelets, a patient gets a recurrence. What do you do at that time? Because it's a common problem.
Yes, we have to understand, as I've shown, that the antiplatelets, neither of them is a panacea. They reduce the risk of stroke by 20%, 15%, whatever. So there will be recurrent stroke in spite of the antiplatelets, might well be because the patient is not well controlled for the other risk factors. So although our kind of psychologically, as a doctors, we'd like to change something. So to do something new, to give as if these were failures. So what you can do, if it's atherosclerotic, based on Pierre Amareco's subgroup analysis of the Socrates, you may give Brilinta also as a potential antiplatelet, which might be beneficial in this particular subgroup patient with atherosclerosis. Or you mean
ticagrelor?
Ticagrelor, yes.
Okay.
Yeah, Brilinta and ticagrelor. The way that Socrates did, although it was not found beneficial in the overall, but maybe in atherosclerotic strokes, it will work better than aspirin alone. So these are the options that we hope to see the results in May, end of May, in sort of the virtual Vienna meeting. And otherwise, we have, in Israel, we have Agrenox, so we have another option of antiplatelet. I don't know if it is existing in India, the Agrenox.
Yeah, it's available.
Yeah. So if it's available, so that's another way. Yeah. Or you should go and look at patients' risk factors, whether they are well controlled, and don't blame the antiplatelet or the dual antiplatelet in the failure to protect from another stroke.
Okay. So what you said is that we should not only blame the drugs, we should also see whether his risk factors are adequately controlled.
Absolutely.
And then,
or whether the patient was taking the antiplatelet.
Yes. Whether the compliance was good. Yeah, correct. Yeah. And if we have checked all that, then we can either change to dipyridamole aspirin combination, or we can now go to ticagrelor also. Now, another question is that after the combination of clopidogrel and aspirin, which is the commonest practice, at the end of 3 weeks or 3 months, when we have to switch to a single antiplatelet, which single antiplatelet do we switch to? Clopidogrel or aspirin? What is the guidance for that?
I switch mostly to aspirin. The guidance does not say which one, because as I've shown you in PROFESS, and as I've shown you in the other studies, there's no really a major difference or significant difference between aspirin and Plavix. Therefore, I think that if the patient was aspirin naive, when he had his stroke, I'll continue with aspirin alone. If the patient was on aspirin when he arrived with his index stroke, then I'll continue with Plavix.
Okay. Now the other related question is that, because we know that clopidogrel can have resistance many times, and which is genetically determined by the CYP. So should we routinely do clopidogrel resistance tests for polymorphism, or you don't think there is any need before continuing the patient indefinitely on clopidogrel? Because if he has a resistance, then we might choose to put him on ticagrelor now that it's available. So what would be your judgment?
I'm not sure that my slides are still, can you see my slides?
Yeah.
So if you look at this in 2012,
yeah,
the FDA issued this regarding the resistance of this one, sorry, 2010.
Yeah.
And they found, this is a very thick paper.
Yeah.
The bottom line is no indication for genotyping for Plavix.
Yeah.
So there is no evidence that the tests that you do in vitro are actually biological valid in vivo. And it's, in fact, you see, if you look at for instance, at the Capristat, had it been that 1/4 or 20% of the patient had been resistant or had this polymorphism, they wouldn't have shown that Plavix is better than aspirin. Which means that probably what we do in vitro, many people do a lot of money with it, but I don't think that, and I do not do any genotyping, and I do not do any in vitro testing for aspirin, neither for aspirin resistance, not for Plavix resistance. So I know that many of my colleagues do that. Definitely, the interventionalists, when they put a stent and they are afraid of stent thrombosis, they do it. And if there is evidence that there is a Plavix resistance, so sort of speaking, they give ticagrelor instead.
Yeah.
But in general, for secondary stroke prevention, I don't think that there is evidence to show. And this is if you like to read it, it's a very thorough paper, and there's no new evidence after that to show that they were wrong.
So there is no recommendation to do it routinely, at least.
No, there's none of the guidelines I know.
Yes.
Neither the American, the European, the Canadian, the NICE.
Yeah. No. Yeah, because you see, this is one of the major problems which all of us face, is when a patient gets a stroke in spite of being on these drugs. So that's where from all these questions come. Now, but you made a very good point that before blaming the drug, we must make sure whether he's taking the medicine or not. Many of the times I have seen patients have actually missed for 2-3 days in a function or during travel and all, and then they get the stroke. So that we need to check, as you rightly emphasize. Now, one question is that there is, in literature, there is a mention that the PPIs, PPI means these antacids and these, omeprazole and rameprazole, they proton pump inhibitors, they inhibit or they reduce the efficacy of clopidogrel as well as aspirin. So is there any need of giving routinely PPIs to these patients, or we should not give it? What do you do? And if you give it, how long do you give it?
I give it only to the elderly, not to the young patient with no evidence of any dyspepsia or whatever. And to the elderly, I give it. And also the question of whether these PPIs reduce the effect of Plavix is controversial. It's not definite. So in these cases, I don't give the PPIs, but the H2 inhibitor. There are many others, not omeprazole. So that's what I do. But definitely, it was shown that if you don't give it to the elderly above 75 years old, then the major bleeding and the fatal bleeding are significantly increased.
And there's a related question that if during acute ischemic stroke, a patient develops a GI bleed, in spite of PPI, a patient develops a GI bleed, then what do? Do you stop antiplatelet agents? Or, and if you stop, after how long you start it? I mean, the scenario is that it's a massive GI bleed. It's not just a simple abrasions or something. What do you do in that situation?
If you extrapolate the data that I've shown about the restart study,
yeah,
with the intracerebral hemorrhage, after 6 days, you can restart in spite of the intracerebral hemorrhage. Definitely, if you have GI bleed, even if a major one, you can either give Plavix, which has less effect on GI bleeding compared to aspirin. That's what I do usually. If a patient has history of GI bleed, but he needs this, usually I say that it's better to bleed from the GI than to have a stroke. So to protect the brain is more important. So you take the risk, you give the Plavix with PPIs or some kind of protectors in order to prevent or to minimize the risk of bleeding. But I think that we know that either anticoagulants or antiplatelets, you should restart. And the guidelines said after maybe 14 weeks sort of, or if you look at the data, after 2 months.
No, after a GI bleed, how long after the GI bleed we can restart antiplatelet? That is the question.
I usually start after 3 weeks, 2-3 weeks.
Oh, so we should wait.
1 month.
1 month.
1 month. 1 month.
Now the other question is, I mean, all these questions are, I mean, I have really faced each one of them problems, what my doctors friends are asking, because all of us face these problems. The question is that normally we say give dual antiplatelets for 3 weeks to 3 months. But does the same thing apply to recurrent strokes also? Suppose a patient is having a stroke 3rd time, and you know this is his 3rd stroke, and you give him this time also dual antiplatelets. But after 3 months, wouldn't you be nervous in stopping it? Because you know he has a history of multiple strokes, and we are not talking of cardioembolic strokes, we are talking of atherostrokes. So what do you, so the question is, how long to give in recurrent strokes dual antiplatelet?
I can tell you that in my practice, again, it's not evidence-based and it's not in the guidelines, but we also need to use the art of medicine and our experience. Yeah. So if a patient has an aggressive sort of behavior, another stroke, and another stroke, another stroke, I keep it on antiplatelet, dual antiplatelet for longer time. And and mainly, in my opinion, it's up to 6 months, even 1 year. And in my experience, I don't see many intracerebral bleeding or major bleeding in this particular patient. I'm not talking about fragile, fragile elderly patient. I'm talking about patient in the 60s, they are fit, and they have recurrent stroke, they have aggressive atherosclerotic strokes. I keep them on dual antiplatelet.
You may keep them for a longer period in this duration.
I discuss it, I discuss it with the patient, explain to him the risk, but telling them, listen, you've shown us that you have a higher risk of strokes, so better to keep you on antiplatelet.
So you may remember that many years ago, people used to give oral anticoagulants also sometimes before the new trials came. People used to give oral anticoagulants, particularly if they had the intracranial stenosis and all. So one question is like this, that in these recurrent strokes, is there any role of adding oral anticoagulants to antiplatelets?
Not by evidence-based. Evidence-based medicine has shown that anticoagulants in ischemic stroke with no cardioembolic stroke are not indicated. Okay. The worst study have shown it, but I've shown you the COMPASS study.
Yes.
COMPASS study showed maybe in the future we'll have this small dose of anticoagulants, NOACs plus aspirin. It could well be, we have to show it, but I think that the future studies will tell us whether small dose of anticoagulant plus aspirin might be better for ischemic stroke, recurrent ischemic stroke than aspirin alone.
I think we have almost reached our time, but I'll take some 2 or 3 important, crucial questions because they are important. And the question is, the prototype question is that there is a patient of atrial fibrillation who is on oral anticoagulants, and this patient gets a myocardial infarction and he undergoes a coronary intracoronary stent. And now the cardiologist wants to put him on dual antiplatelets, Clopidogrel and aspirin, and he's already on oral anticoagulants. Natan, I'm sure you get these patients. What do you do?
First of all, it's a very relevant question because we face these patients many times. And nowadays, there's some evidence in the new studies of the cardiologists to show that even in those patients, dual antithrombotic drugs is better than the triple one. Not better, but the same effect of prevention with no hazard of bleeding. So they nowadays give anticoagulants, DOACs, which has much less bleeding risk, with only mono antiplatelet and not dual antiplatelet. And maybe some of them give it only for a short time, the dual antiplatelet just after the acute stenting for 1 month or 3 weeks, and then they continue only with dual. There's several studies that have shown this, so it's, currently the approach is dual antithrombotic, which means monotherapy with antiplatelet plus DOACs.
Yeah, so that seems to be the way. I've also seen some cardiologists using half dose of, minimum dose of dual antiplatelets but
again, it's not.
Yeah,
it's not evidence-based.
Absolutely. Another very common, frequently encountered problem is when we incidentally see an old asymptomatic lacune in a MRI. I mean, patient doesn't have a stroke. You do a CT scan or a MRI for headache or for a seizure in the elderly, and you find there are many small lacunes there. So what do you do at that time? Do you put them on antiplatelets or you just leave them alone? What do you do? What is the evidence? And about this, look, my question is about the silence.
First of all, there's no evidence. It's just people doing. You see, if you see 2 or 3, 4 lacunar strokes, silent lacunar strokes, so to speak.
Yeah.
You tend to give antiplatelets, but we all know that the small vessel disease are not necessarily atherosclerotic. It could well be there's also only endothelial dysfunction where antiplatelet is useless. So if the patient has any atherosclerosis somewhere, not even significant in the carotid or in the coronary, I put him anyway. And if he has several risk factors like hypertension and diabetes, I put him on antiplatelet. But there is no evidence, it's not based on any trials of evidence-based medicine. My intention is to treat.
Yeah. So you would, in your personal practice, even though there is no evidence, you might give them small dose.
But if you see, because it's not just the lacunes, usually this patient has also white matter changes,
leukoariosis,
and other risk factors. So you put them on I put them on antiplatelet. Small dose of aspirin.
Yes, that's correct. Incidentally, I also you made a reference that you don't have personal experience of silestazole. Now, this silestazole is a very popular drug in some Asian countries. And in fact, if you look at the studies, it has been shown to be even more effective than aspirin. So what is your thoughts on silestazole? It's available.
Based on what, it's not available in Israel, so I don't have any experience with that. But based on the data that I've seen, read, and also the presented data, especially by the Japanese, of course, it was shown that it's very efficacious. So, but I cannot tell you from my experience whether it's really better or the same, equal. Definitely, they have probably less hemorrhagic adverse events.
Yeah. So Nathan, I think you answered many of our questions, but still there are many questions, and I think we have to stay for many hours then, which obviously is not possible. So what we will try, that we will email these questions to you and you may answer, and I will request.
Okay. Did he talk about stopping antiplatelets for cataract and dental surgery? Because
that is a very important question. That's a very important. So
I'm sorry, I couldn't hear it.
What do you advise about stopping antiplatelets for dental procedures or for cataract? Because many of the dentists or the ophthalmologists ask that you stop, and I think you are not supposed to stop, but what is your take?
In high-risk patients, I ask the dentist to press a little bit more. Don't stop antiplatelets. The risk of rebound is higher. It's different with cataract because this is an internal bleeding. It's not something that you can push or to stop by a kind of applicator.
But even cataract, I think, can be done.
Yes.
Without.
Yes. Even I know of many of my gastroenterologists. They are doing endoscopies without stopping Plavix or aspirin. They continue to do it.
Natan,
but
please go on.
Yes.
Please.
What I'm saying that usually it depends on the risk that the patient carries. I mean, if you have a high risk of bleeding, different. But normally, if I have to do it, for dental, I don't think that I never recommend to do it. But if I have to do it, I do this as probably all of us do. Start the aspirin or the Plavix 7 days before. You put the patient on low molecular weight heparin injection until 24 hours before the procedure, and then you restart the antiplatelet if necessary. So this is my policy when I think that there is a risk of bleeding with the antiplatelet. I stop the antiplatelet, put the patient on, in this case, Aspirin or any other low molecular weight heparin for this period of 5 to 6 days, stop it 24 hours before the procedure, and restart it after that.
After you restart after 24 hours? Do you restart
after 24 hours?
Yes.
Or as 24, 48 hours. But again, we have to know if it's Plavix, then we have 4 days the patient is not covered. Because as we all know, Plavix is a pro drug. So therefore, I have an overlap, Plavix plus the injection for 3 or 4 days, and then stop the injections, and then give a continuous Plavix.
But most of our dentists in India don't agree. They will not take the tooth out till they make it sure that.
Subhash,
I always tell my patient, change your dentist.
Yes. And what I do is I give a printout of the American Dental Association, which says you should not stop antiplatelets, you should stop anticoagulants. So I give a printout.